I'm Mark Watson, filling in as Dean of the Woodrow Wilson School this semester. Today I'm very happy to introduce my colleague, Uwe Reinhardt. If you don't know who Uwe is, you probably shouldn't be here. I know him. He had the office next to me for a decade, and it was. I knew he was a great health economist and a wonderful guy in finance and just a sensible guy. But I didn't know what a great teacher he was and how outrageous he was. So when he was teaching econ, whatever it was, 100 or 101, our principles course, he would come into my office, once a week and, tell me his latest opening line in his lecture, and it was always something like, something just completely outrageous, like parents should be able to sell their children. What do you think? Our children should be able to shoot their parents for a fee or something, and he just would always, do something just to wake up the class and get them thinking about important issues. He managed to turn students should be able to shoot their parents for a fee into a fine lecture about supply and demand or something. I don't know. But anyway, I'm not going to waste any of your time by speaking more, so I'm just very pleased that Uwe's agreed to do this. Thank you.
Thank you, Mark, for this kind introduction. Actually, the one question that always amuses me, my lecture on government always gets preceded by the question, who in this class has a mother? I have 300 students, and the maximum I ever got was 25%. So they deny they have a mother, and I say, I agree with you, I wouldn't admit that either. And then liken the American citizens vis-a-vis their government to teenagers vis-a-vis their mother. Usually they say, when I'm 18, I'm not going to talk to Ma anymore. I'm moving out, that's it. And then they get hurt, and where do they run? And that reminds me, so I actually had an editorial, I Hate Mom and the Government Too, and it was printed all over the world because people really like that. Apparently Korean teenagers are just as bad. So today I'll talk about healthcare sailing into a perfect storm, and I'm not sure that story is as well known as it should be, because we talk about the uninsured that we have, but that's peanuts. I'm going to talk about the uninsured we will have, and that's a much, much larger problem. So this is sort of where we are. There's still light, but you see those dark clouds coming from the right. I had some handouts here. One, the hard copies of the slides, and there was also a lecture on the U.S. banking crisis. We have colleagues who specialize in that, but none of them speaks English. Have you ever noticed that? They speak jargon, and it's not any language except what they speak in Bentheim, and it's completely jargon. And you could listen 5 hours and you wouldn't have a clue what they are talking about. A bond, for example, is a put option for the whole company. How would you ever think of it that way? So these guys are smart but crazy. So I have a rendition of it that is understandable. And as usual, it is the French who are to blame. And you can see it there. Now, if you didn't get a copy of that, I put these on the website here that I have, and you can just copy this thing and get it there, in color even, if you want. So let me begin by what we health economists call the 2.5% rule in U.S. health spending. It's actually a little less than that, but we round it up. So if you look at health spending in the past, this is what this looks like. At the bottom, the blue is other private, whatever that is, that must be foundations or grants that are not formally insurance, where somebody supports. Then the green is out of pocket, and it is amazing how little, on average, is really out of pocket. Most of us are very well insured. When you go to the hospital, if you're under 65, there isn't much cost sharing at all. If you're over 65, you pay for the first day. Medicare actually demands a lot more cost sharing than working people, non-elderly people. And then private insurance is the blue, the yellow is federal spending, but that includes the VA, TRICARE, and Medicare, and what the feds give the states to support Medicaid. On average, state Medicaid spending, 65% is federal money. And then the red is state and local. So the state and local pay, but not as much as their wine that they do, actually. Now this has inflation taken out of it, and you can see there are some waves in this thing. There's a little bend that's managed care that came along. But one message from this slide is, you hear the folklore, particularly on Fox Channel News, that it's the government that ruined health care. They drove health spending. It's because of them American health care is ruined. In fact, they're just another player, the government. The private sector, you look at the private insurance, inflates just as much. If you take population out of this, real national health spending, then you get the red line that sort of meanders a little bit, but not a whole lot. And if you have a PhD in econometrics, as Mark has, or you're sober enough to hit trend line on PowerPoint, you get this little black line. And you see God made trend lines to be on it. I mean, the Canadians, by the way, are always on the trend line. No matter what you do, they're a very orderly society. But in the late Reagan era, the health sector went meshuggah. And no one really knows what it was. I think it was the Reagan administration had deregulated the supply side of healthcare, but put nothing in place to strengthen the demand side, and the supply side overrode the forces on the demand side. But God doesn't like it, and if you read the Old Testament, the punishment is frogs, locusts, mud, and stuff like that. And in this case, it was called managed care. That came down on the doctors and the hospitals, and they hated it. But like in Egypt, eventually this stuff went away, and the doctors and hospitals won and defeated managed care. So now it's a toothless tiger. It still calls managed care, but they don't do much. So my model of this is to think of U.S. healthcare as a lumbering elephant that goes down the jungle, and no one can control this beast. You have here the Congress beating on the legs with chopsticks with their feeble rules that always get taken away again. You have the business community totally powerless, shoving this beast. President Obama, but look at how he's positioned. He thinks he's leading healthcare. We shall see. My hunch is this will be ultimately how he'll be carried down the jungle path. Here's the healthcare sector riding this beast. One guy says, nice ride. The other guy says, beats banking, and it sure does. Or automobiles, or fiber optics, or anything you can think of. There is no more stably growing sector in the world than healthcare. You have here venture capitalists who always look at this cash flow, inject themselves in what McKinsey calls the value chain, and take bites out of it. Sometimes they actually add value. Very often they just take value out and add nothing to it. And then here is a health economist watching it all and chronicling it, and that's what I propose to do. Now, anyone who walks into the path of this elephant shares this fate. Here's President Clinton. Remember the Clinton health reform? By the way, Hillary is already in here. And you may not remember Ira Magaziner. He was the Wizard of Oz who designed this whole thing, and there was a guarantee for failure that he designed it. Everyone said, this guy always over-designs everything. Well, he's a little further down the line in this animal. Not inappropriate, in my view. And then you have the private insurers, managed care, trying to tame the beast, and as I showed you, roundly defeated. And this is the most tragic picture of them all. This happens to be the CEO of General Motors, what's left of it, or of him. I'm actually going to send him this. He's a friend of mine. the whole sequence, and so there you are. But it is true, the unfunded retiree health benefits, he told me, of General Motors was $70 billion, and the net worth of General Motors then was $21 billion. So he basically admitted the healthcare sector owned General Motors. And I kidded, said, you're not a car company, you're basically a health insurance company that makes cars to finance itself. Most of his cash flow actually went to retiree health care, not even working workers. So basically, GM practically is bankrupt. It's just kept on a lifeline. So if you look at this little coefficient, that says in long-run average terms, healthcare has grown 4.4% per year in real purchasing power dollars per American. And it goes up and it goes down. Sometimes these are just statistical mirages because they measured the price index incorrectly, or GDP or whatever. If you do the same for GDP in the past, it was 2%. So if you know arithmetic, or if you know subtraction, you can be an actuary and work for the government. Because if you subtract one from the other, you get this 2.5 or 2 to 2.5% rule. Every health economist uses it to make forecasts. And the government actuaries actually use that to make their forecasts. If you now project this into the future, using the 2.5% rule, you get a line like this. This goes from year one, which is, say, today, to the end of the century. And sort of at mid-century, roughly, we'll be spending 40% of GDP on healthcare if we don't somehow manage to control healthcare better than we did during the last 40 years. Now, 40%, the GDP, of course, will be much larger, too. Still, that is a huge bite out of the GDP. There will, in fact, be less of everything else, fewer cars, houses, etc. The healthcare sector would actually bite into the rest of the GDP. Now, if for that money they could get rid of cancer, of Alzheimer's, and have one Viagra pill that lasts 50 years, we might do this bargain. This, what was left over, I mean, you wouldn't basically need it, the leftover. But one really wonders, and I'll show you whether this is necessary. Now, it turns out that Peter Orszag, now the director of the Office of Management and Budget in Washington, he was director of the Congressional Budget Office, the research arm of Congress. He had this little publication, and you can just go cbo.gov and then rummage around in reports, and you'll find it's a wonderful report that he did. I will do a little digression here, by the way. I guess I don't have that in here. So anyway, he made a forecast. The point I wanted to make is the aging of the population does not drive health spending very much at all. Although somebody age 70 costs on average 5 times as much in health care spending than somebody age 40. That is true. The curve is very, very steep. The aging is so gradual. We're now what? About 13% of the population is over 65. That'll go to about 21% in the next 20 years. But that's very gradual. We'll be basically always young. The bulk of the population will be under 65, always 80%, and I think we'll be forever young, not this scary stuff of the baby boom tsunami. That's all total nonsense. It doesn't really drive much at all. Now, if you look at the curve he has in here, he makes a projection. The projection, I'll talk about that in a minute, is pretty much valid only till about 2040 to 50. So I cut it off here, and you see he comes up to 38%. And then the Medicare-Medicaid piece together is 13% of GDP. That's 38% of GDP and 13%. And again, you hear belly aching over what the poor and the Medicare beneficiaries cost America. This is not a big deal at all. The bulk of it is going to still be spent, and the rest of the health care grows just as rapidly, in fact, slightly more rapidly than health care for the elderly or for Medicaid. You see, you talk about Medicaid bankrupting America. It's, again, just a sliver in the whole picture. The great bulk is that most younger people consume more and more health care, and what they get is ever more fantastic. That's what it really is. Now, so Orszag erred by 2% in my book. I had it, remember, at 40 by the year 2050. I don't know where he missed the 2. I'll send him the slide, but that's because he's a government person, of course. Now, I blocked this off because he assumes after, I think, 2040 or 50, that healthcare will grow only as fast as GDP. And that's, of course, hope and prayer. He has the 2.5% rule there only till about 2000, somewhere 45 or so. So I don't even look at the other part of the chart. Now here you have the blue line is the 2.5% gap, and if you got that down to 1%, the way most other OECD countries have it, they do grow, the health systems grow faster than GDP, but only by 1 percentage point on average. If we managed to do that, we would be spending only 23-ish% of the GDP on healthcare by 2050. And that would be quite affordable because the GDP, once we're out of this mess we're in now, will be pretty big. I mean, before this calamity occurred, I calculated that at 1.5% growth of GDP per capita, GDP per capita in 2050 will be twice what it is now. And taking 13% out of that would not be the end of the world at all. What would be left over for all the other stuff will be still much, much larger. So I'm not ever worried about the students I teach or even the younger ones at what they do at 2050. They'll be fine. They have productivity growth, innovation, everything on their side. We don't have to worry about them at all. To my mind, it's their problem. What we need to do is we need to look after our people, our veterans, our waitresses, our cab drivers. That's our mandate now. And if we look after them, we don't take away from those little critters in 2050. It's really their problem. So we must somehow, though, at some point, try to get this line down, maybe not to 1%, but even 1.5% would be great. So let me talk, what's good about this health spending? Well, actually, it turns out, you ask yourselves, whatever happened to the great American economy, which was the darling of the Wall Street Journal? The editorialists, remember, sort of once a week, they write an editorial where they look down on the rest of the world. That's basically what sustains them. Now, this, incidentally, how an economy looks. You teach macro, right? It's a round-shaped thing. And this is what actually drove the American economy in the last 15 years. The consumer drove it very, very much. And if you think about it, those of us who are old enough to remember the 50s and 60s, Harold, you remember, we always assumed 3% productivity growth. We thought there's pi and there is that. Those are the two natural constants. And then that went in the 70s to 1-ish, 1.5-ish. All of a sudden, very quickly, it went down, and the American household's response was the two-earner household. Part of that was that women were finally liberated and could take any job a man could take, but a lot of it was also that people did it because they wanted to earn more money and maintain their lifestyle. And then that went, and then they discovered the credit cards, or it was shoved down their throat by the banking sector. But anyway, they maxed out on the credit card, and then the banking sector came and said, you know what? You're sitting on a house that isn't fully mortgaged, like 90%. That's a sin in America. And everyone took second and third mortgages. And now there's no more credit to be had. Even the Chinese are fed up with it, and as you recently read. And so there would have been a major recession worldwide, because we carried the world with our consumption, even if the bankers had been pristine, there would have been a recession. But of course, and the reason in part, if you look, the bottom 40% of Americans earn 10% of all income. They don't have that money to spend. My profession missed that, I think. Keynes understood it. When you have a highly unequal distribution of income, the people who produce the stuff don't have the money to buy it because they ain't getting it. In the last 20 years, the bulk of the GDP growth per capita went to the top 10th percentile of the income distribution. That's a paper by Roger Gordon. Who is he, Northwestern? Bob Gordon, yeah. I think Northwestern. Very interesting paper where he points that out. And then the top 20% get 60% of the income, and the top 1%, 17%. And so they have all the money, but they don't buy the stuff we produce. They provide Ferragamos and Bugattis and little castles in Italy and stuff like that. They don't spend it on Americans. So I think a highly unequal income distribution creates problems on the demand side of the economy. If you look at wealth is even more, the bottom 40% Americans have zero net worth, zero. I always tell my students, no matter what you do, they'll retire and are totally on your mercy. You will pay taxes like you've never known it before, or your parents have never known it before, because these people all arrive at age 65, zero saving, and huge demand for health care and everything else. And then you have the top 1% who own over a third of the wealth in America. These are 2005 data, and it's Ed Wolf. You have the reference there. But in addition to this consumer-driven recession, we had a banking sector that self-immolated in a way that economists still cannot comprehend, because it's not what we teach. It is never what we taught. All our textbooks are obsolete, literally. I'm glad I'm not teaching freshmen this year, because I would have to rethink how to teach them, because the textbooks would say the markets are self-regulating, business people are rational and efficient. None of that you can tell with a straight face and not have the class giggle at you anymore. So that's a very serious thing. Now, I love to speak about this. I blame this all on the French, and which is good. And I ran off just for fun, so to share with you my view of why you can legitimately blame the banking crisis on the French. I think we should send the Marines over there. But I won't speak about that, but I'll speak what we teach. You teach 512, haven't you? That's the staple. That's what the first equation that we teach in these classes. This is the GDP, and we measure it by all the revenue business establishments get. And it's composed of what consumers spend plus what private businesses or households spend on investment. When you build a house, that's in the eye. And then government. Now, we economists are lazy. We always sort of teach our students G is consumption, or leave them with that impression, without emphasizing that Newark Airport is part of G. Our roads, our defense establishment, all of that, those are investments in our school. Not all government spending is wasteful or consumption. A lot of it is investment, but we don't keep books that way. And I blame our profession for never having insisted that we actually keep books that way, that we segregate government operating spending for the year from long-term investments, like a B-52 is 50 years old, right, aren't they? What an investment. And then you have exports minus imports. Now what happens is, this is the demand side of the economy. Consumption spending is down for reasons I indicated. Investment spending is down. Exports are down. And so if you want to maintain GDP, you got to keep G up. Government has to spend where the rest of us aren't spending at the moment, and that is what is called Keynesian demand-side economics. If you lower taxes right now, I'm not sure what that would do. Maybe a little bit it could prop up consumption, but if you give a restaurant owner, half of whose the restaurant is half full, now you give that guy a tax cut, is he going to expand the restaurant? No, he's going to put it in a savings account, right? So that's not going to help the economy. It's got to be G, in my view, and Obama is, in my view, totally correct on that. Now, health spending, however, is part of the GDP, right? 16% of the GDP. And if you look at the last major recession we had at the beginning of this decade, these are from year-to-year changes. I took the total dollar increase in GDP out of the president's annual report, and I said, what fraction of that increase in dollar spending, GDP, was health care? Between 1999 and 2000, it was a quarter of the growth in GDP was health care. Then it was a fifth. Between 2001 and 2, over half the growth in GDP was health spending. Without it, I don't think without health spending, President Bush would have been reelected. I very much doubt it. And then it was a quarter, but it's a huge chunk of health spending. Here was business investment. That, of course, dragged the economy down, because after the asset bubble, the dot-com, businesses were gun-shy and did not invest. And here was the great housing bubble. Yes, it did drive the economy a little bit, but it pales in comparison to the kick that healthcare spending gave GDP growth. So healthcare spending is one of the major job creators. Michael Mandel came down. He's a good friend. He's actually a PhD, taught at Harvard, and now writes for Business Week, the economics section. And we had this discussion, and he researched it further and found if you actually take the health sector as a sector, it created all the jobs. The other sectors created jobs but killed them too. Right? So you might have somebody laying off 10,000 people, and then 500 small establishments hired 20 people each. But net, the private sector, only healthcare added jobs. So that's something not to be overlooked when you're in deep doo-doo. You don't worry about this at full employment, but when you don't have full employment, you might think that health spending by government might be a very good job creator, or if you did it by running down your savings account and spent it. And it doesn't, I would say, spend on the now uninsured who are underserved, on health information technology, and on cost-effectiveness research, and this is in the Obama stimulus plan. They already put $1 billion for cost-effectiveness research in it. For health IT, I think $50 billion or something in that neighborhood. And then for the uninsured, not yet, although they gave a lot of money to the states to enroll people. So the Obama administration is operating on this. Now, what is the bad in health spending? Here again you have, here is where I put that aside, which I now already told you about. See, here is the age spending profile. This was 1999 data, but they never changed very much, the relationship. If I have health spending for a 40-year-old at 1, then for a 75-year-old, they spend on average 5.6 times as much. You can go to any country, Germany, England, you will find this curve. And yet, I told you, the aging of the population, the fraction that's over 65, rises ever so slowly. I don't know how anyone who wants to be honest could possibly be talking about a baby boom tsunami. This isn't even a ripple. You couldn't surf on this. So this is simply not a problem, the aging of the population, because it's so gradual. Now, the other thing, though, about these are Medicare data that is troublesome is the research done by the Dartmouth Medical School group led by John Wenberg, a physician epidemiologist. And the darker the areas, these are basically county areas around hospitals, hospital market areas, they call it. The darker the color, the more Medicare spends per elderly. Now, those data have been adjusted for the age and gender composition of the elderly in those counties, and even a little bit for morbidity, because they use the Medicare case mix index, which at least captures some of the severity of illness, although not perfectly in my view. But if you look at the range of spending, so here, think of a taxpayer spending either $5,000 per Medicare beneficiary in Oregon, in Minnesota, in Wisconsin, usually the wheat belt states, and $13,000 for the same statistically identical elderly down in Florida, Dade County, Louisiana, all the way across Texas to McAllen. And they tried to relate this to any metric of quality that they wanted to look at, and they find no correlation of these spending variations with outcome, patient satisfaction, or the quality of the healthcare process, where they look, how do the doctors actually practice? This is a troublesome issue. Congress has known about this for 20 years and never responded to it. I remember distinctly testifying before the Senate Finance Committee. Senator Roth was still heading it, and I asked him, you're not supposed to do it, but I did, Senator, can I ask you a question? And he said graciously yes, and I said, as a taxpayer, how can you justify writing checks that are twice as high for Dade County than for Minnesota? How can you justify it? And there was icy silence. He looked around. No one said anything. And later the staffers told me, you shouldn't have done this, because this question is off the table here. Because they say, you happen to be looking at the senator from Florida. And I said, I know him. That's why I was looking at him. Because, no, they said, we will not discuss this. And to this day, it has not been discussed in Congress. The Robert Wood Johnson Foundation has funded all this research. But I believe Peter Orszag, who wrote this report, and it's from his report, as director of OMB, will attack this issue. I think within the next 5 years, people in the Sun Belt will be asked to justify what they're spending. These are the latest. This was February 26, and they actually even found that the spending growth over the last decade, see, the top is if you go to 1992, in Salem, Oregon, we spent $4,000 per Medicare beneficiary, and in Miami's Dade County, $8,000, so double in Miami. But you see, the Oregon hasn't increased much at all over this period. But if you look at Florida, look at how much, much more. So now they're spending about $5,000, I think it is, right? $6,000, and up here they're spending more than $16,000. So the gap is even widening. And I believe this slide is coming to haunt Florida. So if anyone from the Florida healthcare systems, I would worry about what's coming down the pike. So we had a report here. I chaired this commission on rationalizing New Jersey healthcare resources, and I asked the Dartmouth group, can you run for me the numbers you did for the country for our hospital areas in the state of New Jersey? And it turns out, if you call the U.S. 1, the average U.S. spending per Medicare beneficiary is 1, scaling it that way, then in the hospital area of St. Michael's, they spend 3.2 times as much, or Medicare, we, the taxpayer, had to spend 3.2 times as much per elderly in the last 2 years of life than the national average, while down in Atlantic Medical Center, they were equal to the national average. If you look at hospital days, almost 2.5 as much in St. Michael's as nationwide, and so on. Reimbursement per day, why? Because they put them in the ICU up there, and in Atlantic City they don't, and that's where the whole difference is, and length of stay is longer. So I asked the hospital administrator, how can you justify this? And they say, it's not us. We just run free workshop for doctors. They come in here and they order everything, and they can do what they want. We're just a shell sitting here. And so they blame the doctors, and the doctors won't engage in it. If there are physicians here, within the next 5 years, you'll be engaging extremely heavily with the Obama administration over these issues, because that's where the money is. Obviously, this is where they need the money for the uninsured. The challenge, so I say at some point, the Obama and Congress have to muster the courage to ask physicians to explain these variances. My own feeling is if you put better morbidity data into these equations, you might explain some of the variation by morbidity, but not all of it. A lot of it is just extra use. And the Wenberg group thinks, on average, we could spend 30% less per year on Medicare and not hurt any elderly if physicians practiced evidence-based medicine. And that's a major challenge that's out there, and that's what I call a bad, that sits out there, and that needs to be addressed. Now, the only reason we have Medicare data is the private insurance industry hogs their data, doesn't share them, keeps them proprietary. You can't get at them. But I've been at meetings with them, and I've seen there, and they showed me, they have similar variations. Inexplained. They have not been able to control anything. They just put money through, by and large. So that's an issue. Now comes the ugly of this story. And that is, if you look at the employment-based insurance, 2/3 of the American people are covered by private insurance. Only a small fraction of them buy insurance individually. The bulk, something like 90% of those people, get their insurance at the employment. Now, of course, no other country has that system because it's really quite diabolical. Why? Because when you lose your job and you're already down on your luck, you also lose your health insurance. I once wrote a paper, How the Devil Seduced America So. It was actually a speech I gave to the National Governors Association. And I remember the governor of Kentucky really believed that. I think he was from Kentucky or somewhere. When I say we Americans are good people, we would never develop an insurance system this beastly, that when you lose your job, you also lose your health insurance. It had to be the devil. And a lot of governors actually agreed with me. And I actually believe that too. Okay, here are some data. If you Google Milliman Medical Index, you get a very interesting statistic. They have a database of over 10 million insured families under 65. So a huge database. And they have data on what the employer paid towards the premium of the head of household, or house, if there are two of them, the two of them. Plus they have data on what the employees kicked in towards the premium, plus what the employees paid out as pocket spending. Usually you don't capture the latter, but that adds up to a pretty penny too. They actually have a database that has all that in it, and it turns out in 2008, per average family of four, averaged over those 10 million, it was $15,600, which is totally believable because per capita health spending in America is $6,700. So it's totally a believable number. Now it's probably 16,800, something like that. The average compound growth is 9%. Now, if you look at the income distribution of the United States, the green are the people for whom we do quite a bit. Medicaid, food stamps, earned income tax credit, WIC, all kinds of programs for the poor. Not as generous, say, as Canada would be, but nevertheless, for us, pretty good. That's the greens. But the blue are the people between 20,000 and 55. I call them the blues. Those are the cab drivers, the waitresses, the Home Depot, you know, the sales clerks, unless they happen to get insurance at their job. Those people are the salt of the earth in terms of making life comfortable for us in the upper income strata. But a lot of these people are uninsured. Or if they now have insurance, they will lose it in the coming decade because they work for small business establishments very often. And then up there, the yellow is Princeton, New Jersey in this thing. Now, this is something only economists really appreciate, but think of a business and think of all the debits to payroll expense a business firm makes for an employee, all of the debits, no matter who wrote the check to the government, whether it was the employer writing a check for Social Security that the employer owns, has to pay half, or whether it was withheld from the employee, it doesn't matter at all. All the debits that a worker costs, to an economist, that's the price of labor. Therefore, that gross wage base, as I call it, has to support all fringe benefits and all take-home pay. All of that has to come out, no matter who actually writes the check to the government. So when you say employer-provided insurance, where the employer may have given you the policy, but they still debited it to their payroll expense for you, and in fact, we economists believe shifted back to you over time by lower take-home pay. So that's the thing to remember. Now imagine a family with $50,000 gross wage base. That's what I just defined for you. So the total debits for those, one worker, or if they're two, for two workers, businesses made was $50,000. Let that grow at 3%. I looked in the Bureau of Labor Statistics. That's been the average growth in the last 20 years. Let total spending on health for that family, for all items that has to be funded by the wage base, grow at 9%, and then see what happens to the wage base. So here's the wage base that grows from $50,000 to about $68,000. That's the red in the next 10 years. And here is the health insurance, the health care outlay, which is, again, out-of-pocket, employer contribution to premium, and employee. All of that has to be supported by the gross wage base. And if I divide the yellow by the red, I get a line that looks like this. You can see how it climbs up, and in 10 years, over half the wage base goes for health insurance before Social Security contribution, unemployment, income taxes, before any fringe, before anything, half the wage base. Those businesses will no longer give health insurance. This will be the death of that approach to health insurance. Now, economists always say, well, you assumed a certain number. Let me give you the most optimistic forecast, and that is that wages grow at 5% per year, which they haven't, and certainly not in the next coming years with this recession in our neck, and health spending grows by only 4%, half of what it's been. Even then, close to, about 30% of the gross wage base gets chewed up just by health care. So you can see that's what I'm talking about. That is the storm that I'm talking about that's coming down. And we haven't thought how to deal with this. What this means, this is a very nice slide, the Kaiser Foundation, this happens to be the National Institute of Healthcare Management, copying it from the Kaiser Foundation. But you see, being uninsured is very dependent on how poor you are. For people in America who live below the poverty line, a third are uninsured. If you 1 to 200%, poverty line is about $21,000 for a family of 4. So this would be families making $40,000 between $20,000 and $40,000. 30% are uninsured, and so on. And the higher you go, the fewer are uninsured. And what I believe will happen is the uninsurance phenomenon will creep up into social strata who have never been used to that. They'll be politically vocal, and I think Obama, who's a very middle-class focused guy, will in fact be mindful of that, because these people, they will be shocked when all of this stuff happens to them. So that's where we are. Now, therefore, we face this choice in America. In a way, the Canadians don't, the Germans don't, the Japanese, the Taiwanese don't. They don't face these choices, we do. Either we, in the upper part of the income distribution, have to pay more taxes and have to disregard politicians who offer tax cuts. Either we have to do that, or we have to ration by income class. I actually know how to do this in a very cool way. So you can look at God and say we're not doing it. And it's called reference pricing, where you would say to people, look, if you use a generic, we'll pay for that. But if it's a brand name, we won't. You have to pay the difference between the generic and the brand name. If you go to a very cheap hospital for this procedure, we'll pay for that. If you want to go to a more expensive one, you pay the difference out of pocket. And you see how you could gradually create tiers in terms of quality. You know, that you go to one hospital, they don't have an MRI, they get a CAT scan, and the other one has a 128 slice MRI, and you pay the difference. That's how you could do it. So that's what we're facing, this choice. How much would this actually cost? Well, this lovely paper by Jack Hadley and colleagues at the Urban Institute, on average, this was 2008, we spent for people under age 65 about $4,000, while an uninsured equivalent person, the same persons but uninsured, health spending was only $1,600 or 43%. So I am a Canadian, I am not ashamed to admit it, and I always get this, oh, Canadians ration health care. You hear all these horror stories that come down from Canadians rationing health care, as if we didn't do it. Do you think this isn't rationing? Price is ration. I mean, if I tell you, you can have this if you can pay for it, and you can't, I've rationed you. That's what we teach freshmen. So, yes, we ration. We just do it differently in this country than they do it up north. So, using these data, they say, well, we only have to top off the other 57%, and that, for the number of uninsured in 2008, would have been $122 billion in 2008. Now, that is only the stock of uninsured in 2008 and 2008 prices, of course. This will not stay the same. You can't say, well, it'll cost us for the next 10 years $122 a year to get universal coverage. No. I assume here that spending was $125 billion, that covering the people who were uninsured in 2008 would cost $125 billion in 2010. Even that's conservative. And then I assume healthcare spending grows by only 5%, which is probably going to be more, but I'm very conservative. And you can see how annually their budget, the federal budget for the uninsured, for the subsidies, grows to 194, and it's 1.5 trillion, is 1.6 trillion roughly, if what it would cost in the next 10 years to give the subsidies to get you to full insurance to the people who were uninsured in 2008. If that number grew at 8%, you'd be talking 1.8 trillion. And I'll come back to that later. Obama's down payment of $634 billion is 1/3 of the job that needs to be done. And one of the problems is that money is way up in the bushes, like, you know, catching sparrows in the bushes. Yeah, they're there, and you can count them from the bottom, but try to catch them. And that's where that 634 sits. We'll come to that in a second. So what is President Obama's vision? Well, there are two visions. He had a vision. He had the most explicit, beautiful website in his campaign. I mean, you know, you could use it for teaching. It was so good. All spelled out in great detail. But basically, I summarize it, he basically was not revolutionary except for one thing. He was going to just expand the existing system, subsidize employers so they keep giving insurance, taking the most expensive cases out of the employer's accounts. Say if an employee of General Motors cost $80,000, he would take $30,000 and federalize it. Things like that, expanding healthcare for children, S-chip, expanding healthcare for adults, Medicaid. So a lot of that, and he's done a lot of that already. Then there was the new idea, and you can't ever find anyone who ever said to put that in there. All my friends at Harvard who designed this thing said, hey, I didn't do this. But here it was on the website, offering all Americans the choice of a government-run health insurance plan like Medicare. Now, that may be sort of news to Fox Channel News, but a lot of people are envious of elderly people who have a permanent, non-cancelable, stable health insurance system that no one can take away from them. No matter what happens, they have that. And a lot of younger people are jealous of that. Now, you could say Americans hate government. I'm not so sure. An American Medicare beneficiary can choose an HMO, can choose a private insurance. And the private insurance will give them better benefits than they have in traditional Medicare, because the taxpayer pays private plans 14% more per elderly than that same person would have cost in the traditional government plan. Bush put that in there. It's not defensible. There's no defense for this. But it was there. There was the subsidy. When you hear President Obama saying they're subsidized, that's what it was. So the private plans could offer a better deal. And yet 80%, close, I think around 80% of the Medicare beneficiary stayed with a government-run plan. That, we call that revealed preference in economics. That must tell you something. And so I believe we come back to this. It's something that should be considered by politicians. And then, of course, he would streamline the system, look at the Weinberg variation, use IT to hold hospitals accountable, and so on. That was the plan. Now, he made this speech with a $634 down payment. Of that, taxes was $318 billion over the next 10 years. What that is, it's when you make more than $250,000 a year, your itemized deductible usually now save you per dollar mentioned 35 cents if you're in that tax bracket. That's what they're in. That's a tax bracket they're in. And then maybe saves you even some state and local stuff. What Obama is saying, no, we're going to cap that at 28. So if I make a $10,000 charitable deduction contribution to Princeton, I used to have the taxpayer pay $3,500, and it cost me $6,500. Now it'll be 28 is what I save. The taxpayer pays 28, and now that 10,000 cost me 7,200 instead of 6,000. Now the question is, President Shapiro, wouldn't you be lobbying and saying to Congress, geez, whoa, that'll cut charitable deduction? You wouldn't? I remember one of your predecessors, I had a lecture, again, one of those horrible lectures to my students, and what I had told them is, I belong to a club that shoots whales with 50 caliber machine guns. I say, it is the most fun thing you can do. I mean, 50 caliber, the power of this thing, and you see the flesh, and I said, this thing, we structured it as a charitable foundation because whatever teeth they have, we give it to the Smithsonian, and this thing, there is such a club, hunting rare species in Asia, and it's all tax deductible. So I said, you animal lovers, whale lovers, are paying half of my cost of hunting because I can tax deduct it, and with a balanced budget, you got to pay the other half I didn't pay. And the students were just shocked and angry and called me a pig. But then I showed them. A week later in the New York Times, this story about hunting rare species and how that's tax deductible. So I am not sure that 318 isn't a sparrow that'll run away once the whole charity lobby is down there in Washington asking for it. Because I remember Bill Bowen at the time told me, don't spread that too much, because I said there should be no charitable deduction at all. When you want to be charitable, you should do it with after-tax money, and he didn't like it very much. $177 billion is to come from the private insurers. That's the 14% extra they got from Bush. That we will harvest, I'm sure, or not me, but I mean they will harvest. Then the hospitals, there's all kinds of stuff to do to hospitals to weasel $63 billion out of them, and then others. If you look at the 318, I just say, good luck. I was going to say mazel tov, but that's not really what that means, right? I researched that too. So, but if you look at these little items, create hospital quality incentives payments, $12 billion. What is that? Can you put that smear it on a slice of bread? I don't think so. Reduce hospitals' readmissions, $8 billion. You know, somebody just wrote this down. Bundled payments for hospital inpatient. Reallocate Medicare, Medicaid improvement funds. I don't even know what that is. Home payments, etc. And the 177 is for real, I think. But all these other items are extremely ephemeral. I think, you know, they are what business people call synergism. Whenever you have a merger, they speak about synergism. It's 2 + 2 = 5. In fact, it's 2 + 2 = 3 usually, right? But so this is like the Greek synergism. So I'm not sure he's going to get this. Now, the pièce de résistance in the Obama plan, and I use that here in a double meaning, because usually the pièce de résistance is the nicest piece of a dinner, right? Isn't that what it is? But here we shall see. The American people have watched the debacle in the private sector. They have watched the debauchery on Wall Street, and it's the only way you can describe that. See their 401, not 404. I was thinking Sarbanes-Oxley. 401 savings melt away, seeing their promised retiree health benefits melt away, and under the American people under age 65 may therefore yearn for the security of a government program that doesn't go away. Because it's the only permanent thing. You don't know what you're missing. You go to Canada, everyone has permanent. When we fly to Canada, my wife and I always talk to the airline people there about their health care, and you should see the exuberant happiness with that system. And they said, did you ever worry about it? Worry? Why? I mean, it's not an issue. Same in Germany, same in Taiwan, it's only in America that we worry. We don't. We have insurance, not insurance. Because when you're employed, you don't know if you lose your job. You get restructured out of a job, and your insurance is gone. If you have a pre-existing condition, try to get one. So, I mean, I could imagine people really, that there be a large latent demand for this. A candidate, Obama, promised the deal, but the insurance industry, and mainly Republicans it was Republicans on the Hill, resist the idea, say that's the line in the sand. You go across that and we won't play. We'll filibuster in the Senate. Although there is a way to pass it, it's called reconciliation, where you can actually, you don't need only 51 votes. They could pull that trick. Obama could with the Senate caucus. They could pull that trick. It's dirty, but it can be done. Others have done it too. But we shall see. That's why I have a double meaning here. They're resisting it very powerfully. So I'll end my talk with this question for you, because I don't know. Will the president keep the promise that the candidate made in the campaign with regard to this government-run Medicare-like health care plan? I'll give you just a hint, but you can ask me. You can ask me during Q&A what I think about this. So thank you very much. I guess we have some time. We do, for questions. There are mics, or you can shout.
Can I ask you one question? So you showed the real growth in the healthcare spending is roughly about 2%.
Faster than.
So I guess the question is, I know the reason behind it probably very complicated. But what are the main reasons you think that will keep that 2% growth?
That it happened, or not to keep it? I mean, not to keep it, you saw why we can't really afford it. Why it happened is, if you look at all other health systems in the world, in those systems, they are structured to have a fairly strong demand side that can bargain hard with the supply side. In America, in our wisdom or foolishness, we have chosen to splinter the demand side into hundreds of little insurance companies, none of which has a lot of power. I remember Oxford negotiating with Robert Wood Johnson Hospital in New Brunswick, and Robert Wood Johnson didn't like what Oxford would pay them and say, you can take a walk, your patients cannot come here anymore, and Oxford had to cave. And that happened with Sutter Healthcare and WellPoint in California as well. So when you have a splintered demand side and a powerful supply side where hospitals form systems and no insurer can afford not to have that system in their network, then they can pretty much write their ticket. The other thing is that Americans are very technology hungry, or at least their doctors are. We love technology somehow, or our doctors make us like it very much. And therefore, we use it in abundance. I mean, we have more MRI machines than, with the exception of Japan, than anyone in the world. And the government, the Medicare Payment Advisory Committee, has paper after paper saying it's much overused because physicians invest in those things, and we're using too many MRIs. But there's no way to stop it. There's really no way to stop that, because no insurer, the minute an insurer says we're not going to pay for this, the lawyers come out, and if something should go wrong, the tort law will go right after the insurer. So it's very, very difficult, even politically, to do. We have a weak demand side. That's, to me, the main answer.
Okay, thank you. Can I ask one more question, then I will shut up?
Yeah.
On one of your slides, you mentioned the Obama is trying to use some cost-effectiveness way to make the system better. So I think certainly, you can calculate the incremental cost-effectiveness ratio and all those kind of things. But I think it's more challenging problem is how to set the threshold in this country in terms of the cost-effectiveness threshold. Probably even more fundamental question is if we want to set up a threshold, then you need to put a dollar value on a person's life.
Yeah.
And in this country, do you think is it really ready for the public or the politicians or all the people to accept that one American's life is not priceless?
Yeah, it's very interesting you should say that. I testified last week, and there was a Republican who I blog for the New York Times, and that was my blog a week ago. Very much so. Is there a maximum price for a life that Americans say beyond that we won't go? And if there is such a price, is it the same for everyone? Say, is it the same for a rich or a poor person? And I wrote 3 blogs on cost effectiveness. And you can, if you go New York Times Economics with an X and my name, all my posts come up, and they'll be among them. And my point at that stage was, before we have to touch these tricky questions that are really morally very troublesome, there is so much inefficiency that we first have to get rid of, like the Wenberg stuff that I showed you, that we can actually kick this problem down the street, this can down the street, for our kids to solve. We don't really, in the next 10 years, need to address that at all. Because the few cases where it costs $1 million, we can afford it. There are not that many cases. In the long run, though, a society does have to make these calculations. Now, this congressman really went after me, and he was flushed and angry. He damn near called me a Nazi. He did. Well, not really, but he sort of said it's a German philosophy from another era. And I said, no, it isn't. It's in every American health economics textbook. You will find a section on the value of human life. And at Harvard, Kip Viscusi has a whole department in economics devoted to estimating the value of human life. And the way we do this is you observe behavior and decisions legislatures or businesses or people have made, and from that you can actually infer the value of human life that they implicitly, maybe not consciously, put on their life. Orly Ashenfelter, here, my colleague, has a very lovely paper on this topic. And the interesting thing is that the value of human life people put on others' life or their own varies quite enormously. Sometimes they're cut off at $10,000. Sometimes it's $1 million. For example, to give you just one example, our son is a Marine, and they went to invade Iraq, and his unit didn't have enough flak jackets. So the officers gave them to the men, but, you know, he fought that whole invasion without a flak jacket. Why? Because the Army wasn't willing to spend, the Marines wasn't willing to spend it. Why? Because the Congress, the way it all goes to sophisticated electronic stuff, wasn't willing to spend enough on the men. They made a calculated decision on the value of human life. The Pentagon makes it all the time. Next year they went back, and I was sitting with the officer having a brew, and two of them were discussing how to fix a sandbag to the Humvee door. And our son's platoon then was protecting convoys in Anbar province. And I said, you got to be kidding. You don't have armored Humvees? They said, no. And that's the problem. These doors are paper thin, and an IED goes right through into us, so we want to put sandbags on there. They weren't even angry. They were just saying, how does a sandbag hold? I was angry. And I said, you know, look at the calculation. What life, what value does the Congress put on my son's life? And it was always like that. And he went to Afghanistan, embedded with an Afghan unit, and they had one Humvee. And I said, up there in the bush, you should have two in case one breaks down. You need two, right? One to tow the other. Oh, there aren't enough Humvees. It was always like that with the Army. So the Army makes very brutal calculations on the value of human life. I will write to this congressman saying, you, sir, actually did it. Because you didn't bestir yourself to get our, as far as I know, the boys went without the armor. That's all I know. And you can see it, we don't have seat belts in school buses. I think the National Academy of Sciences did a study that per life year saved, it was too high. So I think most school buses don't have seat belts in America. So it is an interesting thing that in every area we already make those decisions, whether we put up a street light or not. For years, down there on Faculty Road, we didn't have barriers at the Dinky, and every year somebody died there. And I actually gave my class an assignment to figure out the price we are putting on human life, and it was something like $2,700. And I actually sent it to Bill, and the things went up real fast. But no, I remember that. I mean, no one had ever thought about it in these crude terms that we health economists do. And only in healthcare do we not make these calculations. And we don't have to for the next 10 years, but at some point we do. At some point, you can have the bionic man that'll cost so much to maintain that we really say you can't justify that and then not educate your kids and so on. Now, in England, they do this. They have a price of $50,000, 30,000 pounds they use if something per life year. And if something costs more than that, they recommend to the NHS not to cover it. Now, the NHS often disregards that. They cover Erbitux, for example, in England, but in theory, they shouldn't. So it's a complicated issue. Fortunately, that isn't Obama's problem. He really can defer that. Yeah.
I really enjoyed the talk. It was very informative and enjoyable. But there's one thing I kept waiting to hear, I didn't hear at all, and that was the enormous waste of private insurance. And you know what I'm talking about, the overhead rate 7 or 8 times, single-payer systems, the requirements of doctors to fill out 40-page forms to save a private insurance company $1. The price we pay for private is estimated to be $500 billion a year. Now, it seems to me there should have been a third choice that we could give Medicare to everyone with no co-pays, deductibles, limitations, dental, all that stuff, and just get rid of private insurance and finance that by the waste that we're going to be saving that it would cost us anything more.
Well, I couldn't more. I have to agree with you. You're totally right. In fact, in our household, we have a division of labor. My wife is up in New York giving 2 lectures on the single-payer systems. So I do the private stuff. No, I think you are right. it's overwhelming evidence that a single-payer system has very low administrative costs. She's talking today about the Taiwan single-payer system. It's 2% of throughput. Medicare is also a little less than 2%. Now, of course, it causes hospitals to have administrative costs, but so do the private payers. There is no question that a private health insurance system costs you money, is more expensive, that I believe unless choice has a lot of value, you get less value for the dollar. But politically, the single-payer thing is just dead. Candidate Obama and President Obama doesn't want to talk about it. There is Congressman Conyers and a group, the PNHP, Physicians for National Health Plan, quite large, actually. They are for it. Quite a few physicians, actually, are for it. But I think politically it really doesn't have much traction. That's why I left it out. Yeah.
I want to tell a little story about a guy named Bill McGuire. Bill McGuire was CEO of United Healthcare, and in 2006 he had to retire because he was caught doing financial manipulations. In 2006, his compensation was $148 million. His retirement plan was costing out $1.5 billion. Now that, at 4%, that's $5 million a month. You can live on $5 million a month. And the goal, the people in healthcare can see this immense wealth waiting for them if they keep their system. So therefore, they spend a lot of money making people like you and me believe that single-payer systems are not wanted in the United States, that people don't support it. They spend money supporting politicians. But it seems to me that people, especially like you, but who am I, but especially like you, have to keep getting these facts out and not leave them out of lectures, but concentrate on them and get up there. Pretend you're Jim Cramer.
Yeah, I mean, I think you have a point, and a valid one. I should have put it in and to show you, because it's easily shown that, in fact, I didn't put any international stuff. I should give another lecture on that. In fact, I do want to give a lecture in the Canadian Studies program comparing Canadian and American ethics, social ethics, which has that in it, and I hope you would come to that. It certainly is true that every country like Canada, in purchasing power parity, spends about half per capita what we spend, half. Taiwan is even less so. Denmark is even less so, and they all have single-payer systems. They are cheap. The danger that sometimes happens with these systems is that politicians underfund them. That has to be said. I believe it's true in Canada. I think they should not have, their queues are too long and too many. They shouldn't have them. Taiwan doesn't have queues, but they also should, my wife will tell you, should spend more. It's a whole separate topic. The really interesting thing would be for her to give a lecture here to walk you through it. Maybe, Richard, you can get that done. Because it's very interesting how Taiwan decided, the way Taiwan did it. They, in 1990, decided we're going to have national health insurance. They convened an international conference. My wife and I were part of it. Americans were there, Canadians were there, and they listened to us, and we said, that's how we do it. And then they decided what they didn't want, and something, they said, the American system, absolutely not. They said, we will not have that. And they sort of took a mutt, a cross between Canada and Germany. That's what they basically decided to do. From Germany, the payroll tax, and from Canada, the single-payer system, and have a very, very fine system, which, however, in my view, is underfunded. So, no, this is an idea that should be kept alive, but we had twice in California a referendum on it, and each time it was lost, each time. And at some point, I actually am thinking of, I had this book sort of sketched out and started to work on it, and then Obama won. Because the book I wanted to write is Losing Sleep Over Health Care Bills. Get used to it. It's your own fault. And I still think I will write it, because you cannot exonerate the American voter for having voted the way they do, right? Because if you had a single-payer advocate in New Jersey, you can be sure of one thing: they wouldn't win. And so you got ultimately to blame Joe the plumber, and 60% of Americans are exactly like Joe the plumber, at least 60%. How else would in enlightened California the single payer never have worked? So that is the problem. You really, at some point, have to say, whom did you vote into power, here or in Washington? And the citizens bear the blame. Well, maybe, but they had some facts, but maybe not the right ones. But nevertheless, if it's such an idea now with blogging, I mean, it should be easy to do. I mean, it's a great idea. I personally believe, if you go out to Canada, there's all kinds of right-wing people there. But if you had a referendum now in Canada, and they are very informed people because they watch CNN. No, they know everything we know because they watch our channels. If you, I don't know, Harold, what you would think. I'd say 75% minimally would say, no way would we even consider an American-style system. Was it? Yeah, would not surprise me. Every time I go out there, they say, yeah, we could do something better, and we could do that. And even right-wing people say that. We should do something better. Maybe if you can't publicly provide the MRIs, we should have some private guys. I wouldn't mind having some private guys owning some MRIs, selling into the Canadian health system. And they have this debate up there. But this, to my mind, unfortunately, Obama is the most feasible plan that I consider is even doable. And the only reason it's doable, because he says, I'm not going to disturb anything very much. And you can guess where this thing with the public plan come out. Let me ask you now, if I ask you, how many people believe a public Medicare-like health plan will survive the health reform that'll probably get passed this year? How many people believe it'll exist a year from now? And how many people think it's going to die? See, there you go. There you go. And I personally am with the latter group for the simple, I mean, for one, the genuflection to Wall Street was just a tad much yesterday. I mean, the shovel isn't big enough, I guess, to shovel the money up there. It's really scandalous, in my view, that you would not consider creating new banks that are owned by the taxpayer for a while. That's Willem Bouter's proposal. And they make loans, and we guarantee their liabilities like we do with banks in general, and let the old banks sit on their assets and enjoy them. And if they're worth as much as Mr. Geithner thinks they are, mazel tov, good for you. And if not, then go bankrupt, because that's how you managed. But somehow to bail out these very people, I haven't looked at bank stocks. I wonder how much the executives who caused all this, how many millions they got richer yesterday when that market went up 500. How many millions were shoveled into their bank accounts, essentially by Geithner? I mean, you have that, and you think you will face down the private insurance industry? I don't think so. So that's where we come out.
Every discussion ultimately includes the phrase evidence-based medicine.
Yeah.
How close are we to evidence? Is it even possible ever to obtain evidence-based medicine based on where we are in the economics?
I think it is certainly possible to do better than we do. I recently read in a very reputable publication, whose name I forget, that only 11% of the guidelines put out by medical specialties are actually scientifically evidence-based. New York Times, good. Yeah, Wall Street Journal it was, right, not the editorial page, the regular section. Yeah, Ron Winslow. I think it was Ron Winslow. And I found that really quite astounding, only 11%. To do this is, of course, very difficult. We should not underestimate. But what business calls operations research, we call health services research. And I think one of all the health spending we do in America, we allocate 1/10 of 1% for operations research. 1/10 of 1%. So that's inadequate. You need a lot more. We, in fact, need a whole new profession. I wish Princeton, well, we can't. We don't have a medical school. But what I have in mind here is a healthcare accountant, someone who knows clinical science, statistics, epidemiology, and some economics. Somebody who has that, an interdisciplinary new degree, that could do this kind of work. What we now have is interdisciplinary teams, and they work pretty well, but it would be better to actually have a professional who could actually do that. I have hopes, though, that this will come. When the Wright brothers took off with that contraption, people told them this will never work. Look at where we're now. I think we will conquer that beast, but it takes a lot of scholarship and a fair bit of money, and I'm self-serving saying that. One more question. Yeah, sir.
Hi. You have not made any comment about the cost of prescription medications,
Yeah.
which actually account for the largest increase in the cost of health care in the recent past. I don't remember the exact statistics, but that's what I read. And we have, the cost of prescription care is just taken off, and something has to be done about it.
Funny, I lectured on that very topic in my course yesterday and showed the class prescription drugs are now 12% of total national health spending. I'll give you some numbers that'll amaze you. 12% of total national health spending. I think it's about 1.4% of GDP. That's all it is. If you take, I used 2005 when drug companies were still making profits. 16% of what they sold was profits. The total profits of all the drug companies was 1.2% of national health spending. And of GDP, it was 1/5 of 1%. So I asked the class, it's a very interesting thing. Worldwide drug sales is 720 billion. Worldwide GDP is 45 trillion. It's not that big a deal. Yet we all are upset about the drug industry. One reason is that many, many people are not very well insured for drugs. So that's the one expenditure they feel, right? It's also something, you have 5 pills and it's $40 and you say, geez, look, the chemicals in it couldn't be more than $1. So you have these impressions there. But overall, drug spending is a problem only. It was for the elderly till 2006, a major problem. And it still is because of the donut hole that is there. You know, if I showed you the slide, you burst out laughing how that law looks, that the percent you pay out of pocket first falls and then rises again and then falls again. It's just totally crazy to do it this way. But overall, I think drug spending, if it were well insured, would not that be that big a deal. For HMOs, it's 20% of their spending because they don't have as much hospitalization because they deal with younger people. Medicare has more hospital stuff, but overall it's 12. So that's really, I told the class, if for social envy purposes you wiped out all the profits of the drug industry, you wouldn't help health spending very much at all. I mean, it's okay to hate them, but it's not going to help you. I mean, there's some people you hate, insurance companies, power companies, you know. You got to have somebody to hate. But it's to me, it sounds like I'm defending them, and I am. If you email me, I'll send you a paper that says, how should we think? The other problem, of course, is we set them up as for-profit enterprises, raw, high-risk for-profit enterprises, but we expect them to behave like the Catholic Church, like non-profit. And so, no matter what they do, if they behave like the Catholic Church, the shareholders get upset. Shirley Tillman says, what happened to our endowment? And if they behave, right? So that the executives are kind of caught in between. Do they sometimes do untoward things? They do. I don't think anything near Wall Street, but nevertheless, there are mishaps there. But overall, I don't think that's the great American problem. The waste that one suspects in the Wenberg variation is, to me, where the harvest is, and not so much with the drug. The other thing is, those drugs, I mean, when they work, they're great. I had E. coli a couple of years ago, and I thought it was just a cold spell. My wife took me down there, and they said, everything is poison in your body. And they gave me some Cipro, I don't know who makes that, Bayer, Cipro. 6 weeks I ate those pills. And I think my out-of-pocket was $600. And I was complaining and saying, geez, $600 for this, you know? And she says, my wife says, my God, I mean, it saved your life. I would have paid $900 for that.